Morning to all of you. And it's a proud day for the Department of Urology at SMS and all our residents and faculty members to have started this class in the new super specialty block. We have all shifted from our old block, the OPD, IPD, and the operation theaters into the new super specialty block. So I congratulate all our members from the Department of Urology. They have worked so hard during the last 1 week in the whole process of shifting. It was just like shifting your whole home to a new place. So congratulations once again. We are really proud of it. So we will start today's teaching session. Today's teaching session is on complications of ureteroscopy and URSL and its management. This would be presented by our resident, Dr. Gaurav Faujdar, and would be moderated by Dr. Manoj, our faculty. So I would request now Dr. Manoj to kindly take over and invite the presenter. Go ahead, Manoj. Okay, you can go ahead, Dr. Gaurav.
Yes.
With your presentation.
Good morning, everyone. So today's topic of discussion is ureteroscopy, its complication and management. My moderator is Dr. Manoj, sir.
Dr. Gaurav, is the echo there also in the hall, or
Yes,
it's just
yes, sir, echo is also yes.
We have to be we have to try to reduce.
Okay. Sir, अभी सर माइक बंद कर दिया सर, अभी शायद नहीं आएगी.
अभी this is better now.
Yes.
Go ahead.
Okay. So before starting about the complication of the ureteroscopy, first we see the appropriate preparation for the ureteroscopy. So the sepsis, active UTI, and untreated bleeding diastasis are the absolute contraindication for ureteroscopy, and usually ureteroscopy is not done in these conditions. Then the sterile preoperative urine cultures usually required just before the ureteroscopy. Broad spectrum prophylactic antibiotic covering the common genitourinary pathogens is started before the ureteroscopy, and use of the sufficient anesthesia is critical. The ureteroscopy usually done in general anesthesia, but it can also be done with the local anesthesia with the sedation. But usually the therapeutic procedures is done under the general anesthesia, because the ureteroscope in situ, and under the local anesthesia, a sudden movement of the patient can be catastrophic when the ureteroscope is in situ of the ureter. So the first step of ureteroscopy is stabilizing ureteral axis. The initial step is the cystoscopy, followed by a retrograde pyelogram to road map the collecting system. So first is to see the ureteric orifice. There are some conditions where there is difficult to visualize the ureteric orifices, such as the man with large intravesical prostate, and also in women with large cystocele. These ureters can be cannulated if the bladder is lifted transvaginally. And in some conditions like previous pelvic or retroperitoneal surgeries or radiation therapy, which can fix the ureter in the deep pelvis. So in these conditions also, the stabilizing the ureteral axis is difficult. And orthopedic abnormalities and contractures, which usually cause the problem in maintaining the proper positioning of the ureteroscopy, and thus stabilizing the axis for ureteral axis is difficult. Some conditions like previously reimplanted ureter, ectopic ureter, and duplicated ureter. In all these conditions, the ureteric orifice is at the abnormal position, and so the ureteric axis stabilization is difficult. If the ureteral orifice can be identified and assessed, then a floppy tip guide wire should be placed in the renal pelvis under cystoscopic and fluoroscopic guidance. The wire should never be forced, because if we forcefully negotiate the wire, then it may be injured. The ureteric wall can cause a mucosal tear or perforation in the ureter. Some conditions like ureteral stricture, ureteral tortuosity, and impacted stone. In these, all these conditions Stone may be injection of lidocaine jelly in ureter.
Dr. Gaurav,
Followed by
Dr. Gaurav, Dr. Gaurav, there is some
Yes.
problem with the voice. Some problem with the voice. Okay, go ahead.
Sir, now, okay. Some condition like the impacted stones in which negotiation of the ureter can be done by the injection of the lidocaine jelly into the ureter, followed by the angled glide wire. But there are some side effect of the lidocaine jelly, which in which the systemic absorption of the jelly can cause disturbance, and a safety guide should be placed prior to any instrumentation in the ureter. Now come to complication of the ureteroscopy. The ureteroscopy complication is broadly divided into two groups, perioperative complication and postoperative complication. The perioperative complication are divided into two part. One is major and another is minor. In major complication, there is ureteric avulsions, which is a very rare complication, ureteric perforation, interception of the ureter, or equipment failure. In minor complication, bleeding, it may be either from the ureter or the kidney, mucosal tear, proximal calculus migration, which is usually not considered as the complication, and extrusion of the calculi from the ureteric lumen, and thermal injury to the ureteric wall. In post-operative complication, divided on the early complications and late complication. In early complication, there may be ureteric colic, which is caused either by the post-operative edema, blood clots, infection in post-operative period, and bleeding. In late complication, there may be ureteral necrosis, ureteral stricture, reflux of the ureteric vasculitic junction.
So I will interrupt Gaurav here. Don't divide into perioperative and post-op. Perioperative means pre, intra, post, all, right? So this is your intraoperative complications that you are describing. Okay. And then you will have post-operative complications, right? Okay. So this is intraoperative. Go ahead.
Yes, sir. So first come to intraoperative complication. In major complication, there may be avulsion of the ureter. So the avulsion of the ureter is usually occurred from the blind forceful manipulation of the ureter. The most common scenario is forceful extraction of a large proximal ureteral calculus that has been engaged in a basket. The most common site is the proximal third of the ureter because it is the thinnest part of the ureter with a lot of fibroconnective tissue in proximal 1/3 of the ureter. The incidence of this catastrophic injury ranges from the 0% to 0.5%. If a ureteric avulsion is recognized, then the procedure must be stopped and a percutaneous drainage should be obtained. Primary repair may be feasible if a small portion of the ureter is injured. But if the defect is large or if the ureter is devascularized in long portion at the site of the avulsion, and then significant debridement is required, and followed which more complex reconstruction like ileal interposition or renal autotransplantation may be required. In some condition, when a large defect with poor kidney functions, then nephrectomy may be an option. The best therapy of this catastrophic complication is the prevention of this complication. If a situation occurs where the stone is entrapped in a basket and cannot be removed, the basket should be disassembled and the stone is fragmented, and never force is applied to extract the stone. This is the diagram showing the mechanism of the ureteric avulsion. In diagram A, passage of the stone basket proximal to the large calculus. In the second, the stone is engaged and retrograde extraction is attempted. When force is applied, note the proximal thinning of the ureteric wall prior to avulsion. And in third diagram, we can see that complete ureteric avulsion occurs. Now come to another complication, which is perforation. Incidence of perforation ranges from 0% to as high as 17%. The golden rule for this is to prevent this complication is to don't pull too hard. Perforation may occur during forceful manipulation of the ureteroscope. It more commonly results from an endoscopic lithotrite. The electrohydraulic lithotripsy and Hofmann yak laser could easily perforate the ureter, while the Paumerin pulse dye laser and pneumatic impactor had a significant margin of safety. The type of the ureteroscope used, either flexible or semi-rigid, was not contributory to the perforation, either flexible or semi-rigid ureteroscope, but there is a significant association with the time of the operative time of the surgery, because longer the time means that difficult the surgery, and if the surgery difficult, there is more chances of the perforation. If a perforation is noted intraoperatively, the procedure should be stopped and the ureter stented in anticipation of a staged procedure. If perforation occur and water or another hypertonic solution is being used, the irrigation should be changed to saline because there is a catastrophic complication of hyponatremia. So the solution should be changed to the saline. The most ureteral perforation will heal spontaneously with a double J stent in place and appropriate antibiotic coverage. Rarely a placement of PCN tube or percutaneous abdominal drain may be necessary if the collection or retroperitoneal urinoma is not clearing. Radiological evaluation is done 4 to 6 weeks after the stent is removed. The diagram showing the ureteral perforation during the ureteroscopy, we can see in the left side that there is periureteric fat can be seen at the site of the perforation. Now come to another complication known as intersusception, which is very rare complication. It involves the avulsion of only the ureteral mucosa. It can occur both in antegrade and retrograde direction. So it usually occurs from the forceful extraction of the large ureteral calculi, also with the ureteral polypoid transitional cell carcinoma, which also cause the intersusception by the polyp growth. Ureteroscopy and stent placement was possible through these intersuscepted segment. So how can we diagnose? So the only suspicious finding was that the ureteric lumen appeared pale white and narrow, and when obstruction developed immediately once the stent is removed, requiring the ureteroneocystostomy in some conditions. So a safety guide wire should always be present prior to any ureteral manipulation, and instrument should be advanced without any force in the ureteric lumen. This is the diagram showing the ureteral intersusception with advancement of the ureteroscope. Another diagram intraoperatively showing that the ureteral mucosa is intersuscepting in the ureteric lumen. Another major complication is the equipment failure, usually caused by the poor vision or malfunctioning of the accessory instruments. So some example of this the equipment failure is the firing of the electrohydraulic lithotripsy probe close to ureteroscope tip, which can crack the lens as easily as it can fragment a stone. Then firing a laser fiber in close proximity or within the ureteroscope can result in costly damage of the lens or other valuable accessory instrument. The flexible ureteroscope are fragile and more susceptible to the damage. So instrument should never be passed through a cystoscope sheath, as thinking of the sheath and of the inlet will damage the ureteroscope. And forceful attempt at passage of instrument through a flex ureteroscope will also damage the working channel. So when any accessory instrument is inserted from the ureteroscope, the straightening of the ureteroscope should be done always. Now come to some minor complication. First is the bleeding, which is either ureteral or renal origin. Ureteral bleeding, which occur from 0% to 2.1% of the procedure. If bleeding is minimal, which can occur from a minimal bleeding can occur from negotiating a stroke through the tight ureteral orifice and edematous or tight ureter or a tight PUJ. Management of these minimal bleeding is usually self-limiting, and by introducing only the sheath or ureteroscope across the area to tamponate that area. Ablation of the TCC can lead to bleed from the feeding vessels. In these conditions, place the ureteroscope above the lesion with irrigation off, and if persist, then place a large caliber ureteral stent for tamponade with a three-way foliage in urinary bladder. Then endopilotomy can lead to bleeding from the UPJ, which is prevented by the cutting true lateral, because cutting anteriorly or posteriorly can lead to injury to the vessels near the pelviureteric junction. If occurs, then place the tip of the scope directly on the bleeding vessel and irrigation off. If brisk bleeding occur, then managed by the angiographic embolization. Come to renal bleeding, which is caused by the pressurized irrigation without use of the access sheath, which can cause significant bleeding from the fornicial rupture. It can lead to formation of subcapsular hematoma, and incidence of renal bleeding subcapsular hematoma is 0.4%. Other risk factors are the thin renal cortex. Patient usually present with flank pain, abdominal pain, fever, vomiting. It is usually self-limiting, and if more severe, then stent placement is sufficient. In case of the brisk bleeding, place the dilator back into the access sheath with wire and wait. If not successful, then go for the embolization or open repair. The diagram below showing the large perinephric collection following during the ureteroscopy. Then come to proximal calculus migration. It is no longer considered as a treatment failure. It prolongs the anesthesia and operative time and may submit the patient to a second procedure. So placing the patient in a reverse Redlenberg position and minimizing the irrigant pressure can limit the proximal stone migration. The stone cone is the newer devices. It prevents the stone migration and promotes the sweeping multiple stone fragment in a single pass while substituting for the ureteric guide wire. The diagram showing a newer stone retropulsion preventing devices. In the left, this is the end trap, and on the right is the stone cone. Now come another complication is the mucosal tear, which is caused by either by instrumental trauma or stone manipulation, usually by the basket extraction, inadvertent application of the energy sources, and excess sheath which compromise the blood flow and induce the ischemia, which later present as the mucosal tear. Mucosal tear is usually self-limiting and will usually heal within 48 to 74 hours with conservative management and drainage with the double J stent. It can progress to a false passage or ureteral perforation. If it is not diagnosed during the procedure. Ultimately, all mucosal tear result in the ureteral stricture formation. If occurred during lithotripsy, fragments of the stone can migrate beneath the tear, which can lead either to stricture or a stent granuloma formation later. This is the endoscopic classification of the ureter wall injury after RIRS using ureteral access sheath. On endoscopic finding, it is injury is divided into low-grade injury or high-grade injury. Low-grade injury is divided into two parts. In grade 0, no lesion found or only the mucosal patches are found. On grade 1, ureteral mucosal erosion without smooth muscle injury is found. In high-grade injury, which involve grade 2, grade 3, and grade 4, in grade 2, ureteral wall injury, including mucosa, smooth muscle, with adventitial preservation and periureteral fat is not seen in grade 2nd injury. In grade 3rd injury, the ureteric wall injury, including the mucosa, smooth muscles, with adventitial perforation and periureteric fat is seen through it. And in grade 4, total ureteric avulsion is usually seen. The diagram showing the grade 1, grade 2, and grade 3 injury. In A diagram, we seeing only the ureteric mucosa is injured. In grade 2, the ureteric smooth muscles also injured. And in grade 3, there is deep injury of the ureteric smooth muscle, and also some ureteric. In grade 3, periureteric fat can also be seen. Another diagram showing the mucosal tear noted after the balloon dilatation in the mid-ureter to facilitate the insertion of the ureteroscope. Now come to extrusion of the calculi. The incidence is between 0.5 to 2.3%. The concern is that the periuteral calculi hinder the ureteral healing and increase the risk of the stricture formation. The extrusion of the infected or struvite calculi may result in periureteral abscess formation. Although the risk of stricture and periuteral abscess formation are very negligible. And persistent ureteroscopic manipulation after extrusion of the calculi to retrieve an extruded stone is not recommended because it can lead to more injury to the ureter. The real risk factor for stricture formation following the extrusion of calculi is the perforation itself and associated extravasation of the fluid rather than the extruded calculus. So stent drainage along with a short course of the perioperative antibiotics is recommended following the extrusion of the stone. Follow-up imaging should be obtained to confirm the adequate renal drainage. And in case of when suspected renal abscess, the infection stone may be followed with a computed tomography scan to rule out the abscess. Patients should also educated about the persistent calculi to avoid the future management by other physicians of these extruded calculi. The diagram showing the kidney, ureter, and bladder after uteroscopy complicated perforation and extrusion of the calculi. Antegrade pyelogram in B diagram, antegrade pyelogram with no obstruction several weeks after the injury and confirmed that the calculus was not in the ureteral lumen. Now come to thermal injury resulting in delayed fibrosis and stricture formation. The ultrasonic lithotripter achieve fairly high temperature and can cause thermal ureteral injury. It's not allowed to cool periodically. Laser have become the most commonly used lithotrites nowadays. The Comarian pulse dye laser is not absorbed by the hemoglobin or soft tissue and is not associated with the risk of thermal injury. The Hogium laser can also cause thermal injury and perforation, but there is a margin of safety if the laser is kept at a distance greater than 2 mm from the ureteric wall. And adequate irrigation is critical during these lithotripsy to allow the cooling and prevent the thermal injury to the ureteric wall. Recently, a pulse solid state laser system that can be used for biliary and salivary lithiasis has been applied for the ureteric calculi. Now come to the post-operative complication. Post-operative complication are divided into early and late. In early complication, it first is the ureteric colic result from the transient obstruction from either ureteral edema, clots, or stone fragments. The incidence ranges from 3.5 to 9%. This can be avoided with placement of stent. Colic often lasts less than 24 to 48 hours. Most one is the infection, which range from low-grade fever to pyelonephritis. And the significant in presence of sterile preoperative urine and use of preoperative antibiotic is rare, occurring on 0.3 to 1.3% of patient only. Infection increases the risk of post-operative infection. If purulent drainage is noted during any portion of upper tract evaluation, the collecting system should be drained and further manipulation halted until the infection is resolved. The ureteroscopy in febrile patient with an obstructing stone is contraindicated and result in the life-threatening urosepsis. So it is usually avoided to do a ureteroscopy in these patients. Come to late complication, the commonest and major complication is the stricture, which is a major late complication that subject the patient to additional procedure, or if left untreated, put them at risk for the renal loss. The incidence of is only less than 2% with uncomplicated ureteroscopy, and a trend toward decrease in the incidence with the advent of the newer devices. The causes of the stricture formation is multifactorial, like impacted stone, ureteral perforation, extravasation, mechanical trauma from the ureteroscope, or use of many accessory instruments which can cause the stricture formation. Histology of the stricture segment usually suggests the chronic inflammation, fibrosis, and urothelial hypertrophy at the site of the impaction of previous stone. Short annular stricture respond well to endoscopic management with balloon dilatation or incision, while longer stricture and those associated with significant periureteral fibrosis are best managed with open or laparoscopic reconstruction. Another late complication is the ureteral necrosis, outcome of a severe intraoperative injury involving intersusception, severe thermal injury, or mucosal dissection. Another late complication is the reflux. VUR is uninfected adult age of little clinical significance. Usually, the patient demonstrates complete resolution of the reflux at 2 weeks post-operatively. Post-operative imaging after ureteroscopy for detection of silent obstruction or stricture formation that may have an adverse effect of the renal function. With advent of the small caliber ureteroscopes, safer lithotripters, routine post-operative imaging is usually not necessary. The stricture was the source of obstruction in post-operative period is only in 0.8% cases. So routine post-operative imaging to rule out the obstruction is not necessary in asymptomatic patient, because the obstructed patient usually present with flank pain. So asymptomatic patient usually not required the routine post-operative imaging studies. Complication of the ureteroscopic management of the upper tract transitional cell carcinoma. The causes of these complications are usually from the loss of access, equipment failure, and bleeding. Perforation is rare, but perforation can occur with the guide wire or the endoscope, or when a grasper or basket is used to biopsy the tumor. The basket or tumor sample should be withdrawn under vision to prevent the ureteral avulsion. Injury is more likely when tissue other than tumor is grasped and the amount of the tissue grasped is large. The ureter can also be perforated with electrocautery if the power setting is too high, the ablation if the ablation is too deep, or if the instrument is misdirected on the ureteral wall. So most ureteral perforation can be managed conservatively with a stent. Thus, a safety guide wire always essential and critical for doing ureteroscopy in patient with upper tract TCC. Once a perforation is diagnosed intraoperatively, the discontinuation of the procedure should be considered to prevent the tumor seeding. Although retroperitoneal seeding after perforation has not been reported yet, larger perforation may require percutaneous drainage or even nephroureterectomy. The incidence of the ureteral stricture after treatment of upper tract transitional cell carcinoma has ranged from 5% to 25%, and these incidences higher than the treatment of the ureteroscopic treatment of the stone. Circumferential or deep ablation are at high risk of stricture formation. The ND-YAG laser may result in less stricture formation than electrocautery. However, the ND-YAG laser may be more damaging than Hogmium-YAG laser because the Hogmium-YAG laser penetrate only 0.5 mm, while ND-YAG laser penetrate 5 to 6 mm depth. Directing the tip of the laser fiber only onto the visible tumor usually prevent the complications. The strictured area should be bite-sized. When the stricture is formed, the stricture area should be bite-sized to rule out a malignant stricture. Now come to last, the complication of the ureteroscopic incision. The complication rates are very low now because of the small caliber ureteroscope and newer accessory instrumentation. The major risk of ureteroscopic incision is intraoperative hemorrhage. An incision at the UPJ may inadvertently cut through the crossing vessels, resulting in immediate bleeding. So incision of a stricture over the iliac vessel or injury of an intrarenal artery during incision of an infundibulum may result in severe bleeding. So the prevention of this vascular bleeding is best treated with knowledge of the renal vascular anatomy. And all the incision at the UPJ should be directed through laterally. Posterior incision should be avoided to prevent the vascular injuries. Nowadays, the use of the intraluminal ultrasonography also to know the exact location of the vessels near the ureter to avoid the injury to these vessels. If hemorrhage is encountered or the patient complains of excessive postoperative pain, then emergent imaging should be performed. Persistent bleeding with a continued transfusion demand and an unstable patient necessitates the emergent arteriography and selective embolization of the bleeding vessels. In rare instance, nephrectomy may be necessary. Other are stent-related complication in the UPJ incisions and urinoma formation. The video showing management of the impacted stone, and they do not force a guide wire past the stone and usually use a access sheet to prevent it to build up an intrarenal pressure.
This situation we like to do is try to read the stone up, and the safest instrument to use is actually a ureteroscope. It's a very blunt tip and it's unlikely to perforate. You place the scope directly against the stone and gently nudge the stone. You can even tap on the stone.
Gaurav, you can mute the video and just give your commentary, right?
Sir?
Continue with the video.
Oh.
The other trick you can use a laser fiber to try to bluntly loosen the stone. Here's a laser fiber here going in, and you try to rock the stone back and forth. By rocking the stone up and down, you're peeling it away from the mucosa and creating some space. And again, the key here is to get the irrigation fluid to go around the stone and bathe the areas when you treat the stone will not cause heating of the tissues. If all else fails, you still can't dislodge the stone. The best way to deal with the stone is to treat the stone by lasering the very center of it. Again, you want to stay away from tissues. You don't want to create a stricture. You don't want to injure the tissues. Stay right in the center of the stone and let those fragments wash back. So if you're using an access sheet, that's nice because the small particles will wash back out from the access sheet. You can use irrigation, and the irrigation force will actually hit the stone and cause the particles to go backward towards you instead of migrating up toward the renal collecting system. What I'd like to do is change the angle of my fiber, come from the top-down approach, I call it. Coming from 12 o'clock, you're much less likely to injure the ureter than if you're coming from 6 o'clock and the fiber's against the tissues. Moving from above, the fiber automatically aims toward the middle of the stone instead of aiming toward the bottom of the stone or the top of the stone. Control the aim of the fiber much easier. So you create a path at 12 o'clock, as you can see here. Once the path's created, you can go past the stone and move the fragments. Also, you don't want to, what do you do about those fragments that are stuck against the mucosa? They're still not coming off. I use my laser fiber here bluntly to sort of just touch the fragments and against the tissue, because you'll get a stricture where you'll embed that fragment into the tissue. So you want to bluntly use your laser flap. I like to use a template nitinol basket of removing these fragments. It's the least traumatic way to remove them. Using a stainless steel basket is more likely to cause injury, but a nitinol basket or a grasper, such as a Dakota or a N-gauge, is useful in this situation to get these fragments engaged and remove them. And of course, always inspect the collecting system for pieces that have migrated up. Even in the best circumstances, if you think you didn't get any fragments up, you'd be surprised how often.
So finally, tips to prevent these complications are preoperative management, proper preoperative management like preoperative sterile culture, preoperative antibiotic, proper anesthesia, proper knowledge of the anatomy by the surgeon. The golden rule is the don't pull too hard. All instruments should be checked preoperatively. Instruments should be advanced without force and under vision where possible, and careful use of the energy sources. Finally, small take-home message is don't pull too hard. Thank you.
Thank you, Gaurav. You can just try. Thank you. I can see Dr. Munir Khan here. Dr. Munir Khan, are you here? Can you just unmute yourself? And Dr. Kavishra was also there. So if they can unmute themselves and if they have any comments to make, I would invite Dr. Munir Khan, who is a very, very senior urologist from Srinagar, Kashmir. You're most welcome, and we are really honored to have you in our session, Dr. Khan. Anyway, so any of the residents or faculty have any kind of query or comments to make, then I will make my comments. So if you have any comments, please go ahead.
Yes, sir.
Yes. Neeraj, go ahead. Yeah.
So Gaurav, good presentation on your behalf. It mainly focused on, I think, the complications related to rigid ureteroscopy, right?
Yes,
but
sir.
Nowadays we are using, more and more flexible ureteroscopy and RIRS also. And I think there are a couple of complications in RIRS that I think we should have focused in a bit more detail. And more specifically, the infectious or the septic complications that you see following RIRS, right?
Yes.
So RIRS is associated with a significantly higher sepsis rate as compared to rigid ureteroscopy, right? And I think you must have read what are the factors which predispose RIRS to more infectious complications. So could you just elaborate why RIRS is associated with a higher infectious rate?
Gaurav, right, as Neeraj has rightly pointed out, not only RIRS, even URSL would be have a higher urosepsis rate than when we are doing PCNL in patients with renal stones, right? Renal or ureteric stones, whatever it is. So what do you think is the main problem in RIRS and URSL? So go ahead.
Sir, I think ureteric stones have the obstructive system usually, which usually infected.
Right. So they may be an infected system, yes, but usually you get a urine culture done, make it sterile, and then again, yes. This is a very important part of making the urine sterile before you do a URSL or RIRS. So what Neeraj is asking you, why RIRS is more has more chances of infection than URSL? So where do you actually, in RIRS you are trying to hit the stone in the kidney, right? So what about, how do the infection goes into the systemic circulation? So the stone may be infected, the system may be infected, and when you are instrumenting, the instrumentation itself can cause ascending infection. All these can cause infection, but how does it go into the systemic circulation? If so, the main problem here is Neeraj, would you like to comment, and then I would go ahead. Neeraj, go ahead.
Okay. So as sir pointed out, Gaurav, the character of the stone, the nature of the stone. When you are fragmenting it, the bacteria may release into the lumen, and they may cause infection. But the main reason why it is associated with a higher rate is probably because of the increased irrigation, right? The irrigation, or somewhat the pressure irrigation and the pressure which they use, it is associated with a higher infection. And this infection may spread through what we call as the pylolymphatic and the pylovenous channels. So whenever you have a higher intrapelvic pressure, the bacteria which are dislodged by disintegrating the stone, they gain access into the circulation, and this predisposes to a higher sepsis rate. And so one should be very careful during RIRS, or for that matter, even rigid ureteroscopy, that your irrigation pressure should be kept at the bare minimum possible, at which you can visualize the stone and at which you can fragment the stone, and never use too much of pressure irrigation.
Right. So as rightly pointed out, RIRS, URSL, you are working in a closed system. It's always already an obstructed system. Chances of infection are more. And then when you are using more irrigation with more of high pressure, then there is a chance of pylovenous, pylolymphatic backflow, which can result this infection goes into the systemic circulation and the chances of urosepsis. So all these are very important factors. We have Dr. Munir, who has unmuted himself. Dr. Munir, are you there?
Yeah, it's also depends on the time taken. If you have a prolonged case, lot of time, then also we see urosepsis, and we should be very careful in that. And the other thing is that we need to give antibiotics prior to this instrumentation RIRS. But with the thulium laser coming in, the things have changed. It's much faster disintegration than the holmium laser.
All right. So thank you, Dr. Munir. First of all, most welcome to our teaching session. We are really honored to have you in our teaching session. And then when you talked about this thulium laser, definitely it is more rapid in the process, but do you think it, as one of the limitation or one of the drawback is that it increases more temperature? So we do not know whether it causes more thermal injury in ureter and
I don't think in the kidney it matters, because the irrigation is quite a bit. Right. But in the ureter, yes, I think we should be careful, because some of the cases when you do this URS with the thulium laser, you post procedure, you find that burn over there. Right. So in that case, I think in the kidney, I don't think it matters.
Right, right. So you are very correct in that. You have to be very careful in doing a URSL while with thulium fiber, though it is very fast. People have adopted to thulium fiber laser as recently. Dr. Kim is also there. Dr. Kim, would you like to comment anything? And it's really a pleasure to have you in our session.
Another reason could be the stone burden. Higher the burden, chances of sepsis is high. Right. Second is it an infected stone or a non-infected stone? That also can be an important factor for sepsis following RIRS.
That's true. That's true, because always if it's a impacted stone, there will be an obstructed system. The chance of infection would be high, and even the systemic infection would be higher.
Another factor is if you're not using the access sheet, then the pressure goes up. If you're not using the access sheet, the proper access sheet.
All right. So yes. So again, if you have a good access sheet and your ureteroscope is a thin ureteroscope, the pressure gets released, and so that can help in releasing the high pressure and can reduce the infection rate. That's right. Anybody else? Anybody has to make any comment? Well, I will just make few more comments here. One is about the complications. For Gaurav, whenever we do the complications study in a particular procedure, the usual system is the Clavian-Dindo classification, right? So Clavian-Dindo classification is a kind of a general classification for post-operative complications, and they have used it for intraoperative complications also, but it is not specific for URS. So Gaurav, are you aware of any URS specific classification of complications. Nimeshji, I would request kindly mute others, please. Yes. Mr. Gaurav, Dr. Gaurav. Your voice is not clear. Yes, go ahead. So there are two complications, there are two classifications which deal with URS specific complications. That is, one is SATAVA, SATAVA, and one is the PULSE classification, which is more specific to URSL. So when we are dealing with complications of URSL, we should try to focus on that particular classification system. There is a very important study that has been done in for intraoperative and postoperative complications of URSL ureteroscopy. Are you aware of that? Are you aware of any very large studies, global studies? So one of the important studies was a CROSS. There's a Central Research of Endourological Society study which was done in just a few years back. And they did a study on almost 12,000 patients for about, I think, maybe about 20, 30 countries around the globe. And they found that post-URSL, both the intra and post-operative complication rate was around 7.4% in URSL, and the stone-free rate was around 85.6%. So that's a very important study, which was a very large study on 12,000 patients. Was done in almost all the continents and in almost many countries. So again, the intra-op complication was around 4.2% and post-op complication was around 2.6% in these patients. So we have to be aware of definitely these complications before we do the size of ureteroscope does matter a lot. Basket, again, you didn't mention about the type of the basket to be used. Usually the tipped baskets have more chances of injury. So the tipped basket usually passes by the side of the stone, and once it goes above the stone, it may be difficult to pull the stone sometimes, and you can cause injury also. And again, there is a chance of when you use the laser, you can injure the basket also. So when these tipped baskets, they are arranged in such a way that if you injure one of those wires, these wires will be pointing into the ureteral mucosa, and you will not be able to pull the basket. So that is why it's very important that you use the tipless baskets. The tipless baskets are less injurious than tipped baskets. And most of us usually use these baskets in a very, we don't use very often nowadays. And then important complication is when you are passing the guide wire. So if the guide wire doesn't pass through the normal lumen, sometimes it may go submucosally, sometimes it may perforate the ureter. And there was one very interesting study, case report, I just came across recently, that this guide wire which had passed up into the thorax, and the stent was found to be in the heart. So this is a very interesting, and the patient didn't die, and they could remove the stent, which was actually lying in the upper part, was proximal part was lying in the heart. So you have to be very careful while passing these guide wires and stenting these patients, and do give a liberal use of the dye when you are doing ureteroscope. So you have to see the system properly, do an integrated study properly, see whether your guide wire has passed in the correct passage or not, and then only proceed for URSL. That's very important. And always keep the ureteral lumen in sight. So when one of the chances of injury is when the ureteral lumen is not in sight and you're trying to force the ureteroscope. And another thing is, it is always better to have interrupted irrigation rather than continuous irrigation. So you do not know how much pressure usually is being applied there. And with interrupted, you can control your irrigation system. And then about the avulsion of the ureteric injury, yes, definitely, if it is avulsed, you have to either do an open or laparoscopic repair of this avulsed ureter. But there is one interesting study from Middle East. They had endoscopically managed the avulsed ureter. And I have the video also. We will show you sometimes this video, how they passed a guide wire through the avulsed proximal ureter, and they could just pull the proximal ureter down and pass a stent. And after 6 weeks, when the stent was removed, the patient was perfectly all right. So this is one of the anecdotal kind of a case report when the endoscopic management of avulsed ureter was done. Another study that we are using, one of the important reason why you cannot pass the ureter, besides the size of the ureteroscope and the lumen size, is the muscle spasm sometimes which happens in the ureteric wall, which doesn't allow the instrument to go up. In that case, we are doing a study on aminophylline. We are trying to inject locally aminophylline, which is a vasodilator and a dilate which causes smooth muscle dilatation, and doing a study in which we are trying to see whether this helps in the easy passage of ureteroscope. So I think these are all things which we need to be, and the most important thing is be very careful while doing URSL, never force, never pull. All these things are very important. Otherwise, you can land up in a very, very grievous kind of injury to the ureter, and you will actually make the patient's life hell, or even sometimes these patients have died also after URSL. So thank you very much. Dr. Manoj, you have anything to comment on as a moderator? Any other faculty member or a resident, if he has any query, please go ahead. Okay, so if nobody has any other comments to make, I would once again thank Dr. Munir Khan, Dr. Kim Mamen, and I could see Dr. Kamishra also join our session today on Zoom. So thank you very much, all of you, to have joined our session today. And I think many of the, yes, Dr. Munir, thank you very much. Thank you. So, and there must be many people who might have joined on YouTube also. So thank you very much. Thanks, residents. Thanks, faculty members, and have a good day. Thank you very much.